My name is Tim Brewerton, and thank you for coming today, even though it's the last day of a wonderful conference in a wonderful place. We're going to be talking today about the integration of ultra-processed food addiction diagnosis and treatment into a combined eating disorder substance use disorder program. I always like to start off talks with a good quote, and this is one of my favorites that I think is appropriate for the topic, which is from Arthur Schopenhauer, who was a German philosopher. He said that all truth passes through three stages. First, it is ridiculed. Second, it is violently opposed. Third, it is accepted as being self-evident. And I think this applies to food addiction as it is applied to many things that we know, such as behavioral addictions and other addictions throughout the history. Today, we're going to be talking about the historical development of food addiction, or what is better termed ultra-processed food addiction. We're going to be talking about its clinical implications, how you assess it, some epidemiological studies, the neurobiology of food addiction, as well as treatment approaches and how SunCloud Health approaches this issue. It's one of the few programs in the United States and the world that really treats both eating disorders and substance disorders together and acknowledges the reality of food addiction, which has been a controversial topic in the eating disorder field, especially. And then we're going to talk about the process of training and supporting clinicians who work in the program, and then finally ended with question and answers. So food addiction, or ultra-processed food addiction, has been a rapidly emerging concept since particularly 2009, when Ashley Gerhardt published the Yale Food Addiction Scale. Thousands of peer-reviewed articles have substantiated its validity and have explored its clinical relevance in both psychiatry and medicine. However, it remains controversial, and it's not yet been adapted by the ISAM or the ICD for reasons that will be discussed. Although the phenomenon of food addiction, or ultra-processed food addiction, has been well established and is reinforced by the recent introduction of the NOVA food classification system, treatment research studies are in the early stages, and evidence-based practices are not well established or adopted by clinical programs, especially in the eating disorder field. This is a paper by Nguyen on the history of food addiction research, and you can see that there's been an explosion of research articles published according to the Web of Science, particularly in the last 15 years or so. If we look at PubMed, to the end of August, there have been over 4,400 peer-reviewed articles published on this topic, and growing. This is a figure I took from the Mule article about the review of history of food addiction. And it goes back to 1956 when Randolph talked about food addiction to corn, wheat, coffee, milk, eggs, and potatoes. And then, of course, in the United States, most people are familiar with Overeaters Anonymous, which also acknowledged that food addiction exists. So back in the late 50s, food addiction was a widely used term. And then as eating disorders became acknowledged, particularly bulimia, addiction like eating, addictive personality was written about in terms of bulimia, anorexia, starvation dependence, chocolate addiction. Moving on up to the present, where brain imaging studies in obesity and binge eating disorder and food addiction have occurred. And then there have been animal models of food addiction, and now the assessment in humans. So it has become an increasingly useful and defensible clinical entity with marked implications for policy, research, and practice. And the basic idea is that highly palatable foods consisting largely of very high added sugar content and high fat are postulated to act via very similar mechanisms as both illicit and licit drugs with use in the brain. There's a lot of data to support that. Much of the work in humans, as I've said, has been facilitated by validated, reliable assessment instruments. And since the YFAS was first published, there have been forms for children, YFAS for children, that's been shown to have good retest reliability and validity. Then a variation based on the DSM-5, the YFAS-2, and now a modified YFAS-2, which is down to 13 questions. You'll be hearing about our use of this a little bit later. And then very recently, just in the last couple of months, a structured interview called the Food Addiction Symptom Inventory has been published by Erica Lafata, which is adapted from the structured clinical interview for DSM-5. So the food environment, as we all know, has changed drastically in a relatively short period of time. And foods are now being processed in ways that increase its reward potency and the speed of absorption of fat and sugar into the system. And there are these two factors that increase the addictive potential of other substances are well known, particularly coca leaves, which people chew regularly and don't get addicted to, but when it's processed into cocaine, it's a whole other story. This is the modified Yale Food Addiction Scale 2.0, and it shows you the kinds of questions that are asked, such as I ate to the point of being physically ill. There are issues around tolerance, withdrawal, craving, all of the same kinds of symptoms that we see in the DSM-5 criteria for all substance use disorders. They're directly derived from these criteria. And we see that score is basically indicative of how severe food addiction is, or the substance use disorder is, with a score of 2 and above being mild, or what Tom McClellan might call pre-addiction. In his talk, we saw that, but then moving on up to moderate and severe forms of the disorder. Just like other substance use disorders, as well as in the eating disorder field, if you're familiar with that, comorbidity is the rule rather than the exception, and this certainly holds true for food addiction as well. Since the description of food addiction by Gerhardt, there has been an explosion of studies that have substantiated its validity in phenomenology. And this presentation will briefly review the existing literature on the associations of food addiction and co-occurring psychiatric disorders, which together have a pronounced negative effect on quality of life. So this is a list of all of the comorbid conditions that have already been reported in association with food addiction or ultra-processed food addiction. Eating disorders being at the top of the list. There's a significant overlap, but it's not a one-to-one correspondence. Mood disorders, again, like in eating disorders and other substance use disorders, are very, very common, as are anxiety disorders. Of particular interest to me has been post-traumatic stress disorder, which we're going to be talking about, and I think which is really important to assess when you're treating food addiction. And then other substance-related and addictive disorders, but also ADHD, schizophrenia, other psychotic disorders, autism spectrum disorder, you may or may not know, has been associated with eating disorders. A significant minority of individuals have symptoms on the spectrum, and then personality disorders, and last but not least, are non-psychiatric medical disorders. This is a busy slide, but it shows you some of the similarities and differences between anorexia nervosa restricting, anorexia nervosa binge purge type, bulimia nervosa, and binge eating disorder, which are the predominant eating disorders out of DSM-5, compared to the symptoms and signs that we see in food addiction. And they all, or many of them, certainly have binge eating episodes. and excessive food consumption, a sense of lack of control or loss of control eating, which is common to all of the binge type eating disorders and food addiction. And then obsessions related to food, distress in relation to food, social and or professional consequences related to food are all associated features. So there's overlap and there are important differences. PTSD, as I mentioned, there are high rates of symptoms found in individuals meeting criteria for food addiction, thereby linking earlier traumatic experiences and their downstream effects as potential etiological factors. The preferential ingestion of highly palatable foods may serve to self-soothe or self-medicate negative emotional states and to thereby dampen arousal and facilitate numbing and avoidance, symptoms characteristic of PTSD and related psychopathology. In a study of over 57,000 adult participants in the National Nurses Health Study in the United States, lifetime histories of childhood physical and sexual abuse in 2001 and then current diagnosis of food addiction in 2009 were obtained. So this is one of the very few prospective studies showing a relationship. And 80% of those with childhood maltreatment histories met food addiction criteria, and severe physical and sexual abuse were associated with a 90% increase in food addiction risk. The relative risk of food addiction for those with histories of abuse was 1.92 for physical, 1.87 for sexual, and when you combined the two, which also co-occur, it went up to 2.4. Other forms of childhood trauma, emotional abuse, emotional neglect, which are very common, physical accidents, disasters were not reported, nor were symptoms or diagnoses of PTSD reported. However, this is showing a graphic representation of this data that I just mentioned to you. So as the severity of sexual abuse increased and the severity of physical abuse increased, you see there's an additive effect in terms of the risk for developing food addiction later on. So because it is a prospective study, it does suggest that trauma and PTSD, as I'll show you, play etiological factors in the emergence of food addiction. This, Susan Mason continued looking at PTSD symptoms, and this is in over 49,000 participants, again in the National Nurses Health Study, and the prevalence of food addiction increased with the number of lifetime PTSD symptoms. Women with the greatest number of PTSD symptoms, 6 or 7, had more than twice the prevalence of food addiction as women with neither PTSD symptoms nor trauma histories. So we see a very strong relationship between symptoms of PTSD and food addiction. And it did not differ by trauma type. However, they did show that the earlier the trauma occurred, beginning in childhood or 10 years old, the more there was an association with food addiction. You could see those with trauma beginning before age 10, those occurring in adolescence had the most high association with subsequent food addiction. I want to just let people know, if you're interested in this topic, there's a brand new book that just came out after many years of compilation by Ashley Gerhardt, Kelly Brownell, Mark Gold, and Mark Potenza. Know those names, I'm sure. And this just came out a couple of months ago. It's available in print and as an ebook, and it's a very comprehensive overview of the recent literature on this topic. And with that, I'll hand it over to Kim Dennis for continuation.
Hi, everyone. I'm Kim Dennis. I'm the medical director at SunCloud Health and one of the co-founders, along with my husband over there taking pictures of me. I'm delighted to be here with you today. I'm also a person with lived experience and over 20 years of sobriety from alcoholism and food addiction and bulimia. So this is a topic that's near and dear to my heart, and I've been treating it for about 20 years, despite much resistance in the eating disorder world. And I'm going to talk about prevalence and neurobiology. So the prevalence, I'll start with at the talk that the physician from the WHO gave on the workings of the substance-related and addictive disorders group. I asked if they were doing any work on food addiction. And his answer was, well, there's a different group that's doing obesity and there's a different group that's doing eating disorders. So much like Dr. Brewerton said, I think it's important to know that food addiction is a distinct diagnosis from obesity. Many people with obesity do not have food addiction. And it's also a distinct diagnosis from binge eating disorder, bulimia nervosa, anorexia. Many people conflate those as well. The prevalence varies widely depending on the study and the sample. And it's estimated that 12% of children and 14% of adults in non-clinical samples have food addiction. So much like alcohol use disorder. In eating disorder samples, we see that patients, particularly with bulimia nervosa and binge eating disorder, have rates anywhere from 70 to 90%. Also interesting is the fact that in studies of people with anorexia nervosa, up to 50% of that patient population will score positive on the modified, the MyFAST, the Yale Food Addiction Scale. And many of those people don't actually have food addiction. We know that reward sensitivity increases in a way that it's inverse to weight. So when somebody's malnourished, their brain is in a malnourished state, their sensitivity to reward, particularly around highly rewarding foods, can subjectively feel to themselves like they have an addiction to the food. But most people with anorexia nervosa, many people with the restricting subtype of anorexia nervosa exhibit over control and do not have out of control eating, even though subjectively they feel like they're out of control. We know, again, as Dr. Brewerton mentioned, that food addiction is associated with a whole host of comorbid psychiatric and medical consequences, particularly on the medical side, type 2 diabetes, high cholesterol, cardiovascular disease, osteoarthritis, chronic pain, in addition to the psychiatric comorbidities, as were mentioned before. We also know that food addiction, patients who have food addiction tend to show more insecure attachment styles and higher impulsivity, and that's consistent with other addictive behaviors. In eating disorder treatment centers, there's a lot of stigma towards addiction in general. Other people that run eating disorder clinics in the United States often say things like, they get those addicts out of my milieu. They scare my patients with anorexia. They're so out of control. They're so impulsive. So there's a lot of stigma in general in the eating disorder world against addiction, and a lot of pushback around the concept of food addiction because people associate it with diet culture. If you tell somebody that they have food addiction and they're addicted to a certain food substances, then you're just going to be supporting them in restricting. So there's a lot of focus in the eating disorder world on over-controlled eating disorders, anorexia nervosa particularly. For good reason, it has a very, very high mortality rate. But the overwhelming majority of patients with eating disorders have out of control characteristic eating disorders, bulimia, binge eating disorder, and then other specified food and eating disorder. There's research that shows health disparities and health inequities in food addiction. And I think this is important research. In the US, a nationally representative sample revealed that the presence of ultra-processed food addiction was substantially increased, particularly among Hispanic people and Black people when compared to white people. And food insecurity as well has been associated with a substantially increased risk of meeting criteria for ultra-processed food addiction. And it's thought that these disparities are driven by two factors. One is the food industry, which there's evidence in the research database now that shows that ultra-processed foods are disproportionately marketed to persons of color using exploitive techniques taken out of Big Tobacco's playbook. And the accessibility and affordability of ultra-processed foods is widespread and growing worldwide. And it correlates in the United States and in other countries to food industrialization and the widespread availability of cheap ultra-processed foods. So the neurobiology behind food addiction is similar to the neurobiology behind addiction. And I think it's really important. In the DSM, we use substance use disorder, alcohol use disorder, cocaine use disorder, which I think lends itself to people believing that it's about that the substance causes the illness versus this is addiction, right? And there are many different things that feed addiction, if you will. But the ventral tegmental area, the dopamine hit in the nucleus accumbens, we see the same prefrontal cortex abnormalities and impaired executive control. Reward saliency is turned on. The brakes, inhibition is turned off. And you have the dorsal striatal loop going back down as well. Which has substantial overlap with eating disorders and OCD, right, habit formation. It's a bit more complicated than that with addiction as well, but certainly for food addiction, because there are so many other limbic areas of the brain that are involved in the experience of eating. Taste, texture, memory, the somatosensory cortex, the insula, the hypothalamus with regards to satiety and satiety cues. Many patients with food addiction will say, in the eating disorder world, intuitive eating is a pillar of nutritional treatment, right? So people with food rules, with anorexia nervosa who are over-controlled, a big part of the treatment is helping those folks, break the rigidity, right, and eat in a way that they're connected to their bodies. They can sense when they're hungry and full and actually honor that. They can have all sorts of foods, all food fit. And with people who have food addiction, the treatment can be, you'll hear a little bit more from other members of our team here about what protocols we use. There are many types of treatments for food addiction, but one of the treatments is an abstinence-based approach where you actually support people in, abstaining from certain types of food substances, right? People often say, well, we have to eat. I understand with alcohol you can not drink, but we have to eat multiple times a day. But we also have to drink multiple times a day. If I stopped drinking water, I would die sooner than eating. So it's really about the type of substance and what it does to the brain and the person. There's a context is a really important part of this. But many people with food addiction seem to not have awareness, even years and years and years into recovery, of fullness and satiety states. And I believe that's neurobiologically driven. The dopamine system is involved. We know that there both rewarding values of food and substances of abuse and other behaviors like gambling, sex, increase the level of dopamine in the nucleus accumbens, and there's a compensatory downregulation of dopamine receptors in that circuit. So exactly the same as we see with other substances. We also know that the opiate system is involved. Both alcohol and high-fat sweets can cause release of endogenous opioids. And there's the cascade of neuroadaptation that occurs. We know, again, that the potency of the agent ingested and the rapidity of it crossing the blood-brain barrier are important factors in determining addiction potential for any substance that we ingest. We also know that just phenomenologically, just like with addiction, many of these behaviors are carried out in secret. And particularly as an eating disorder professional, among patients that come in without eating disorders or food addiction, they have alcohol use disorder, PTSD, bipolar disorder. There's sort of a hierarchy of substances, right? The people who are using alcohol, then there's the harder drugs, then there's the people who are addicted to fentanyl. It's similar in the eating disorder world. The shame and the stigma increase as you go down the rung. And people with anorexia are sort of like, that's what everybody wants to be, if that makes sense. I wish I had more control. And people don't like to share about out of control eating. I think people don't like to, in treatment and outside of treatment, it's a highly stigmatized behavior, and we stigmatize people of size all the time as well, right? Repeated cycles, if you continually repeat this cycle over a long course of time, the person's hedonic state shifts from a positive hedonic state to a negative hedonic state. And it's not about getting high anymore, feeling good anymore. It's really just about keeping your head above water. So people often say, how could food really be addictive? Like drug addiction. What about the loss of control and the inability to function? And those people are thinking of the top picture as that's what addiction is, right? But if we look at somebody who's addicted to nicotine, for example, many of these people function. Many of these people have jobs. They perform at their jobs. They get up for their smoke breaks and go outside. So it's thought that food addiction is most closely resembling tobacco addiction. And this is the NOVA food classification system that Dr. Brewerton mentioned. And it was created not too long ago, maybe 10 years ago, out of Brazil. And it's a way of classifying food in the degree of processing, industrial processing. So unprocessed or minimally processed foods would be group 1, and that would be whole foods, plants, seeds, water, milk. Then the next category, category 2, is culinary ingredients. And these are ingredients that are derived from group 1 through processing that might include pressing, refining, grinding, milling. Then there's group 3, which is processed foods, and that's made by adding, now we're getting into the business of adding to the whole foods, right? So adding salt, oil, sugar, other substances from group 1 or from group 2 to group 1 foods. So bottled vegetables, fruits in syrup, freshly made breads. A homemade cake might also be in this category, which is a little bit problematic when we're considering that we're calling this ultra-processed food addiction, because people with food addiction who have a fresh baked cake from home or one that they buy in an instant from Instacart, again, have the same brain reward, the similar brain reward response in addiction. And then group 4 is really the group that is highly, highly problematic for people with food addiction. And that would be ultra processed foods. And these are foods that are made in a lab. Nicole Avina, who's one of the prominent researchers in this space, really pushes back on even calling these foods because they're largely chemicals. And, foods they're derived from foods, but added chemicals. So this would include soft drinks, sweet or savory packaged snacks, and reconstituted meat products. Why does processing matter? Again, if you chew on a coca leaf, it's a very different experience than snorting cocaine. And the same could be said for sugarcane, right? Sugarcane in itself has a fiber on the outside, and that fiber, this is similar to fruit juices as well. If you eat an apple, the fiber on the outside of the apple slows down the rate of glucose spike that you get that is relevant to the reward center. If you have it in a bottle of Dr. Pepper or in a bottle of Mott's natural organic applesauce that has a bunch of sugar added to it and no fiber, you're going to have a very different glucose response than if you chewed on sugar cane. Dopamine tone in the reward circuit has 3 parts. Dopamine release, the number and function of receptors. And again, we said for people with addiction, including food addiction, receptor density is downregulated and decreased. And then the time that dopamine is available at those receptors. We know that release has multiple factors involved in it. Receptor is in part, receptor density is in part determined by genetics, but also by social position. So there are studies that show for stigmatized groups, for minoritized groups, for groups that have had high burdens of trauma and isolation, that in and of itself, before addiction even starts, decreases dopamine receptor density. And that's relevant, especially when we take into consideration that many groups that have all of that also are economically deprived, right? And food insecure and don't have access to whole foods, but have access to, Twinkies and packaged foods, convenience, quick packaged foods. So when a person comes into recovery with low release and low receptors, how do we help them? We can help with release pharmacologically. And there needs to be another part of it, right, to increase dopamine receptor density back up. Otherwise, they're never going to be getting the reward of showing up to a conference like this with colleagues and giving a talk, right? Because they're used to the supra physiologic reward. And part of how we help people, this is why psychosocial, spiritual aspects of recovery are so important, because that kind of connection, whether it be to care provider, a group, peer recovery support, actually increases dopamine receptor density. With regards to reward circuitry and binge eating disorder, again, I mentioned this before, we know that the orbital frontal cortex is impaired, just like we see with regards to other addiction. And the top-down moderation of eating is impaired because of that. The brakes are shut off. We're not going to talk much about the GLP medications here, but one of the things that they can help with is, for people with binge eating disorder or food addiction who are on the GLP medication for type 2 diabetes, they often say, I feel like I can, I have a lot more flexibility and freedom with my food. I can actually stop when I'm full. I feel when I'm full. And part of what that helps with is this top-down executive functioning when it comes to food intake. Most studies of bulimia nervosa and binge eating disorder show reduced dopamine-related circuit responsiveness, just like with substance use disorders. And in anorexia, there's increased dopamine-related responsiveness, again, because in part, because as weight decreases when people are in states of starvation, they have increased dopamine responsivity. Many of the early studies on humans for food addiction were done by Ashley Gerhard, who's another prominent food addiction researcher. And this was one of her first studies using 48 healthy young women, a whole range of BMIs. And they measured the relationship between elevated food addiction scores on the YFAS and functional MRI activation in response to receiving a milkshake or anticipated receipt of a milkshake. And this is what they found. So as you increase food addiction scores, so as the people who had the highest food addiction scores had the highest levels of activation in the medial orbital frontal cortex, which lets us know what's rewarding and what we're attending to, right? If you walk into a grocery store and you have food addiction, your gaze goes to the sweets, the packaged foods, not the vegetables and potatoes and other foods. And then the lateral orbital frontal cortex, the brakes, the inhibition, what you see is we could just look at the people who received a milkshake, which is shown in the black bars. The people with high food addiction scores had the most shutting off of their brakes, right? And the people with lower food addiction scores still had some, but it was significantly higher than those people with high food addiction scores. Glycemic load has also been connected to reward, and high glycemic load foods, which cause higher glucose spikes and higher insulin release and much lower glucose levels 4 hours postprandially, tend to trigger the reward center much more profoundly than low glycemic index foods. Glycemic index tells us how carbohydrate-containing foods affect glucose and insulin. We know that this is one of the studies that looked particularly at high glycemic index versus low glycemic index foods. And they studied men and gave them high glycemic index milkshake and a comparator group that had the same caloric value. It was a milkshake. It was also sweet, but it was low glycemic index. And they looked at what happened both in brain reward centers and in insulin and glucose spikes. In the men that had the higher glycemic index milkshake, the drop in blood glucose 4 hours postprandially was associated with excessive hunger and intense activation of the nucleus accumbens. And this is particularly relevant when people are trying to make decisions about what they want to eat when they're hungry, right? If the nucleus accumbens is screaming for quick, fast dopamine, you'll be much more likely to, go for quick, fast food rather than I'm gonna stir fry some vegetables and, make some rice and, have some tofu or vegetable or chicken. So the conclusion of the study was compared with low glycemic index meals, a high glycemic index meal of the same calories, decreased plasma glucose, increased hunger, and selectively stimulated the brain regions, which are associated with reward and craving in the late postprandial period. Okay, that is all for me, and I'm going to turn it over now to Research.
Hi everyone, my name is Nguyen, and I'm the research coordinator for SunCloud Health here. My main responsibility, so I work with our data collection, also assist in training our clinical teams just on how to use our survey data. Here's a little bit about our data collection process. So our patients take our set of assessments right at admission through any level of care. So with SunCloud, we currently have residential level of care, partial hospitalization, and intensive outpatient program as well. As our patients step down or progress through the programs, we take another set of assessments at step down. Patients take another set at discharge, 6-month post-discharge, as well as 1 year post-discharge as well. Here's the demographic information that we collect from our patients. So making sure again to collect which level of care the patient admits at, as well as the level of care that the patient discharges at. We also look at our patients' diagnoses. So if our patients have an eating disorder diagnosis, as well as any comorbid diagnoses, being able to record that as well. Looking at weight, height, BMI. For our patients, we also look if they have a history of treatment. So looking to see if our patients have a history of residential treatment, also any inpatient treatment prior to coming to our programs. And then also looking at social determinants of health, such as any of our patients' levels of education, and then also household income. Here is an overview of the assessments that we use. So in our program, we currently use 13 assessments as our patients are moving throughout our program. So for addictions, we utilize 4 different types of assessments. The first one being the DAS-10. This one is our drug abuse screening test. And it provides us an idea of our patients' current drug use behaviors. Very similarly to the DAS-10, we use the audit SR, which looks at alcohol use behaviors in our patients. As mentioned prior to, we utilize the modified yellow food addiction scale, which looks at our patients' food addiction or addictive like eating behaviors, and also allows us a DSM-5 criteria to whether a patient fits the diagnosis for food addiction. We also utilize our own survey. So this is the SunCloud Health Screening Survey, which is a mix of looking at our patients' age of onset for trauma, and then also for drug and alcohol use, and then also behavioral addictions such as gambling, shopping, and we also have other questions on internet use and other things there. For PTSD, we have 4 different surveys that we use. The first one being the LEC-5, which is the life events checklist. This one allows us to identify any DSM-5 criteria and traumas. For example, those would include sexual assault, physical assault, any big accidents that have happened to our patients, and they're able to write in if they've witnessed the trauma, if they've learned about it, or if they've had the trauma happen to them. We also use the PCL-5 or the PTSD checklist for the DSM-5, which is a diagnostic tool used for PTSD and allows us to look at the symptoms through cluster B through E. We use the dissociative subtype of PTSD scale as well to look at current lifelong and current symptoms for the dissociative subtype of PTSD. We also use the ITQ, which is the International Trauma Questionnaire, which allows us to look at complex PTSD symptoms as well as PTSD measured through the ICD-11. So for eating disorders, we use the EDEQ, which is the Eating Disorder Examination Questionnaire, which allows us to look at current eating behaviors for our patients. And the main focus is split into 4 different categories where we're able to look if a patient is currently experiencing any restriction, any shape, weight, or eating concerns. Also, very similarly in the SunCloud Health Screening Survey, we do look at age of onset of the behaviors for our patients. For mood disorders as well as quality of life, we use 3 different assessments. So the first one being the PHQ-9, which measures depressive symptoms of major depression in our patients. And then also looking at the Spielberger State Anxiety Inventory, which measures symptoms of state. So either lifelong feelings of how the patient is experiencing the anxiety, or trait, which is how they're currently experiencing their anxiety. The other one is the World Health Quality of Life Survey, which allows us to look at overall how the patient is currently rating their quality of life. So how do we use the data at SunCloud? The first one I would say is that we use these surveys as a means to individualize our patient care. It's a way to merge our clinical assessments, whether that be through our intake team or even from our patient's therapist, with measurement-based treatment. So again, merging our survey results with initial clinical assessments. The surveys also provide us a snapshot of how our patients are currently doing, whether that's right at admission or as they are progressing throughout our program, especially for any of our patients that step down from a residential program to a PHP. Oftentimes we can see increases in urges, especially for substance use. So we see an increase in alcohol, our alcohol use scale, or for our DAS-10 scale, so any drug abuse. So just being able to measure that as our patients progress, and also having an understanding or baseline of where our patients are currently rating in terms of their depression and anxiety. Our tools are also used as a means to track patient progression and regression throughout our program, and of course for our research study. Oftentimes we hear a lot of pushbacks when we have our patients take surveys and also just implementing surveys into a program with a clinical team. From our patients, we often hear that the surveys take too long, the survey questions don't make sense, and then from our staff, I think understanding that or being able to answer that question of why do we need these survey data when we already have so much information about the patient prior to them coming in. Also looking like how do we interpret these numbers, and then how do I talk to my patients about their scores. So for our clinical staff, I think it's very important to just emphasize the importance of our survey information. Like we mentioned, having measurement-based care is important to us here at SunCloud, to be able to emphasize that importance of, hey, being able to have these scores about our patients are important in your day-to-day treatment with your patients and also in any treatment updates that you have. I think also for our staff, just being open to making guides or visuals on how to interpret the patient data and being knowledgeable of how we can explain that to somebody who may not have previous survey experience, and also being open to continue trainings on data interpretation in group and individual settings. It's also important to just be able to utilize survey data in day-to-day life, whether that's just in our staff meetings where we speak about our patients and look about different treatment methods. For our patients, it's a means for our patients to feel heard. Right? It's a way for our patients to be able to show us where they are currently in terms of their treatment and in their care. And also providing our patients a choice of when they would like to take the surveys, being able to say, I know on your first day, it can be a lot. So would you like to take the surveys later on in the day, the next day, being open to listening to our patients in that way. And then also, as the patients are taking the surveys, being able to support our patients through answering any questions, also being available for when the patients are done with the surveys to answer any questions or just be an avid support. We have a couple of vignettes on how we've used our surveys with our patients. So for this patient, we have a 39-year-old white woman who at intake had reported that they had no previous diagnosis of an eating disorder or no ED history treatment. When this patient took the ED-EQ survey, they had an overall score of 4.33. So for the ED-EQ survey, there is a cutoff score of 2.8. So any patient with a cutoff score higher than that, there is a suggestion of the presence of an eating disorder. So once we receive these scores from this patient, we're able to get this patient set up with a consultation with a registered dietitian, where it was confirmed that they did engage in recent restriction behaviors, and be able to provide this patient an additional meal support space where they felt more supported while they're eating their meals, and also being able to provide this patient a meal plan and further education. Another example here is for our PCL5. So this was our PTSD scale. So we have a 26-year-old female Black patient who did not have a diagnosis of PTSD or unspecified trauma. As this patient took their admission surveys, we had a score of 72, which is quite high. The cutoff score for the PCL5 is 33. To be able to look here and say, oh my goodness, this patient most likely or does have a PTSD diagnosis. So from there, being able to let this patient's clinical team know, their therapist, and then also just being able to let their psychiatrist know just in case there are any additional medication changes that need to be made. And then also ensuring that we're following a trauma-informed model with this patient. And then at discharge, this patient's score decreased from a 72 to a 30. Thank you.
Thank you, Cindy. Thank you for helping us get this program off to a great start. So I'm going to talk a little bit about some of our findings now from the first 288 patients. I'm sorry, yeah. 200 and something patients. 88 of whom met criteria with the modified YFAS 2.0 for food addiction, which indicates a score of 2.0 or above is positive, versus those who scored below a 2, which is 165. So approximately a third of the population that we've examined so far meet criteria for ultra-processed food addiction, according to modified YFAS. So we're just looking at independent t-test at this point. And we have all of these measures that Cindy has told you about, and I'm going to show you some of our preliminary data and what they mean. First off, you can see that those with food addiction diagnosis, which are in red, are a little bit younger than the non-food addiction group. And again, this is, again, a substance use disorder, eating disorder program. So most of the people have substance use disorders of some kind, in addition to the food addiction. And so they're a little younger and they're also significantly heavier, according to BMI. The average modified YFAS score is a little bit above 5 compared to those who don't have food addiction. When we look at diagnosis and race, we see no significant difference across, although there is a tendency for most of the patients to be white. There's no significant difference across racial categorization. When we look at sexual orientation, again, we don't see any significant difference by chi-square. However, when we look at gender identification, we see that those with food addiction do tend to be female. When we look at the eating disorder measures using the eating disorder examination questionnaire, we see that those with food addiction score higher on the EDEQ global assessment score, which is an overall average of all the different subscales. And you can see the subscale scores are also highly significantly different from those without food addiction. When we look at other comorbid measures, we see significantly higher measures of depression, higher measures of state anxiety, higher measures of trait anxiety, but no difference in terms of alcohol use or drug use. Those scores you see there are high. So overall the population is using a lot of alcohol and has a high rate of substance use disorder and other drug use disorders. They're no different. I mean, food addiction, no food addiction. When we look at the PTSD and complex PTSD, we see across the board significantly higher scores in those with food addiction. Whether we're looking at the PCL5 scores, which is based on DSM-5 criteria for PTSD, whether we're looking at ITQ, International Trauma Questionnaire PTSD scores, whether we're looking at complex PTSD disorders of self-orientation, that is higher. We're looking at dissociative subscale of PTSD scores and the different subscale scores. We see significantly higher rates across the board. And then we also see on the LEC5 higher rates, higher numbers of different trauma types in those with food addiction. So we see across the board much higher trauma and higher sequelae of trauma in the ultra-processed food addiction group. To date, no one has previously reported higher rates of complex PTSD symptoms in a food addiction population, nor have they reported on the dissociative subtype of PTSD being higher in an ultra-processed food addiction sample. So these are very important and kind of new data for the field. When we look at food addiction diagnosis and other comorbid diagnoses, we see, again, not unexpectedly higher rates of eating disorder diagnosis, but also PTSD by DSM-5 and ICD-11, as well as complex PTSD, major depression, but no difference in a DSM-5 substance use disorder diagnosis. They're equivalent to those without. But that they all have very high rates. Those are very high scores for having substance use disorder. And then when we look at quality of life as measured by the World Health Organization Quality of Life Brief Scale, we see the higher in the physical domain, or physical symptomatology in those with food addiction, and slightly lower in the psychological realm compared to a large group with a larger economic substance use disorder, and no difference in environmental or social relations subscales. So in summary, we have significantly higher BMIs, rates of obesity, scores of eating disorders, trauma and trauma sequelae, dissociative subscale of PTSD, as well as complex PTSD, depression, state trait anxiety, higher rates of all of those kinds of diagnoses. So we have generated kind of a confirmation of the high rates of psychiatric comorbidity that we see in this group, like others have found. And then similarly high rates of alcohol and substance use disorders per DSM-5, and higher physical subscale scores and lower psychological subscale scores. Nikki Bishop will take us home.
Thank you, Dr. Burns. Hello, everybody. I'm Nikki Bishop. I'm the clinical director at SunCloud Health. So I oversee the clinical work and training clinicians and such. So I'm going to go a little bit over those pieces. So first, just to start, as a psychologist in my own training and a lot of the clinicians that we work with, there is very little, if any, training on eating disorders and none on food addiction that I've experienced. So one of the most important things to do is start off with going over psychoeducation and talking through, like Dr. Kim was talking about a lot, there is a lot of myths that our registered dietitians and our clinicians, well, not as much our clinicians, but more our registered dietitians believe about food addiction. So that's a very big piece in working with them and talking through it for both our clients and our staff. Psychopharmacology. When we're working with our clients, we need to include our entire multidisciplinary team in how we're going to treat the patient overall, because our patients, each of our patients have each of their own individual needs, and we very much want to look at the entire context and the entire picture for the client and not miss anything that might be very unique for that client. So together with that, we use the psychoeducation piece. We do any psychopharmacology. We also do a lot of medical monitoring as our patients are starting off, whatever level of care they're starting off. So it might be residential, and then they could step down, hopefully so, to our partial hospitalization, then our intensive outpatient. And through that, there's medical monitoring. We also work with the client on any sort of movement therapy that's needed, and work with the registered dietitian and our entire team in general on nutrition therapy. One of our big core pieces that's also been talked about within our program is spirituality and the 12 step principles. And so that's a very big piece to bring together the holistic picture for the client. And that also helps some of the rigidity in thinking and working with patients and some of the cognitive distortions that are happening to open it up so that we're able to make some bigger impact for the client. And like Dr. Brewerton and Dr. Kim were both going over, the context that we see for a lot of our clients is trauma, PTSD, complex trauma. And that's a big piece that we need to address and work with on the client so that they can actually get better as a whole. I'm not sure quite how to move this, but I figured it out. So we have a bit of a nuanced nutritional philosophy. Like I was mentioning before, our individualized treatment plan that we come up with each patient is very, very specific. So we use a very weight neutral, size inclusive, adaptively intuitive eating plan, and various nutritional intervention protocol that go into place along with it. We'll work with our patient individually to come up with a meal plan that makes sense for them, right? We can't have some sort of generic plan that doesn't make sense for them, because otherwise, how is it going to be effective for them later on? And we'll have them identify different foods and eating behaviors, which regularly diminish their capacity to exercise adaptive dietary restraint aligned with whatever that person's authentic values are, right? Because when we're working with the clients, we need to know what's important to them. What are their goals? And otherwise, then they're just going to be focused on what we're asking them to do rather than having any buy-in into the treatment. So what is our different nutritional interventions that we'll utilize? So when we're working with clients, based off of whether they're openness, sometimes they're not open to, like we've talked about a lot, based off of their history of eating disorder treatment or any knowledge that they've gotten before, they might be at different levels of how open they are to even acknowledging or having insight or accepting or being open to a potential food addiction diagnosis. And so we'll start off and give different options and meet them exactly where they're at in that given moment. So one option that will work with them and show them is treatment as usual. Let's do what we'll work with you on that nuanced meal plan, and we'll move with you from there. And those are the standard eating disorder dietary approaches that are taken. Then we look at a harm reduction approach. So again, meeting the client exactly where they're at. How can we, sometimes an example of what we'll do is we'll have them list foods that are the most addictive for them in what are their red foods. They're always problematic. What are those yellow foods that are kind of, what are those yellow foods that are sometimes problematic, but don't always trigger that food addiction to the same degree? And what are those green foods that are never problematic? They're the easier ones that we can look at. So we'll start kind of like an exposure piece with that and list them and start decreasing red foods out of their meal plan when we're working with them to create that meal plan. And then, like Dr. Kim was mentioning, we have our abstinence-based approach where we'll help them in getting whatever those red foods are completely out of their meal plan, right? And again, there's a lot of stigma on that because a lot of people in the eating disorder world see that as restricting, like Dr. Kim was mentioning. And so we'll work with them in that NOVA for foods categories to see where do those foods match in those categories. So that's part of the nutritional interventions that we use. All right, so now I'm going to talk about training clinicians. And like I was mentioning, the registered dietitians, a lot of them, they come in with a very strong knowledge set of what it means to treat an eating disorder. And they also, a lot of times, are very rigid in what that could look like, especially when food addiction comes up. And again, with our clinicians, they're open to it, but they have no idea really what we're talking about or what to even look for a lot of times. So we have to do a lot of training to get that figured out. So I'm going to talk through a little bit about that. So one of our first steps in doing that is who's the key stakeholders, right? Who are the people who are treating the client, who are working the client that actually could help make an impact in shifting what helping that patient recover, right? So a lot of times we'll start off with leaders in our organization, in addition to any sort of registered dietitians that may be working with the patients. We'll also work with the clinicians, the therapists, the psychiatrists, the nursing team, our nurse practitioners. So we'll always work with everyone. So we kind of have to figure out what groups, and we'll do different trainings based off of where they're at. So a training for the registered dietitians where they have a bit more rigidity in coming into and being open to this training might look a little different than the training that we're doing for the clinicians. So just, this is a small example of a way that I've worked with some of the clinicians to do some training. So our registered, after we've done a lot of work with our registered dietitians, we've brought in consultants and helped to give the research of what's going on, and even our own research for the clients that we're working with. So what I did is I helped to empower the registered dietitians and help them to meet our clinical team where they're at and feel empowered in, this is what we know. So an example of what we did is we put all these foods out on a table and we had our clinicians try to guess because they weren't even sure where they are at in those know before categories, right? So we would have them look at it and kind of guess. So if any of you are interested, take a look, think about it, see what matches. And as you're doing that, here's the answers. So you can see Dr. Kim went over a lot of that, right? And even as I was learning it, I was still trying to figure it out as well. So we're kind of all working together in this process and doing it. And it was kind of surprising. But you could see those ultra processed foods at the bottom that are in that fourth category. All right, so what are some of the other training mechanisms that we'll use when working with our entire team? So again, what are the gaps in knowledge that we need to teach? What is the different, how do we empower the registered dietitian? So we have various group supervisions at each of our locations and for each of our types of teams. So our registered dietitians have a supervision where they've had a consultant come in and talk with them about food addiction. We will discuss it in our group supervisions that we have at each of our locations, right? We also have weekly staffings where our entire team comes together and talks through each patient for 5 minutes every week. And in those, we start asking a lot of questions. What's going on with this patient, especially the leaders, like I was saying, those key stakeholders. We're training them to be like, hey, therapist or registered dietitian, how is this coming up? Have you seen this, right? Because it's not used in the everyday language. So we're having to integrate that in a lot of the language that we're utilizing. We're also having to take a look at, are there some false positives that we're seeing in the MyFast screener, right? Because when the patient might have very severe anorexia and the scores are a bit subjective in that realm, it might be a false positive in some sort of way for the patient. So we're having, let's take a look. What were their answers, right? Or any sort of secondary food addiction. We also will do ongoing training. Cindy has been an amazing part in helping us do training for clinicians on these different screeners and making sure they're starting to utilize it when they're looking at their patient. And we'll also ask questions like, what did you get? What did the patient get on their YFAST or their MyFast screen assessment when they're doing it to see like, hey, this is where we're at and this is where we need to go, and making sure that they're actually looking at those. That has been one of the hardest things that we've had to figure out, is making sure that the clinicians are integrating this data into the treatment. So there's challenges and a lot of training that's going into that. And what's the congruency between their MyFast score, their history, what does it look like? What is their relationship with food look like growing up? What is all of the contextual pieces? What is their maybe other addiction background? What is their trauma history? What are these different pieces that all come together to actually show that there's this diagnosis? And so just an example of what we'll use for a diagnosis is F1920, other psychoactive substance dependence, since it's not in the medicine. Okay, so here's an example of what it's been like to train the registered dietitians in integrating food addiction when they're treating it. So I use the stages of change here because I think it's a great example of the rigidity sometimes of how our brains become more flexible and our cognitive thought processes. So as you can see, we might start off in the pre-contemplation stage of I've learned about food addiction and it doesn't exist. Or I haven't learned about food addiction, it doesn't exist, right? I'm not going anywhere near that. Then in the contemplation phase, I mean, I know it exists, but I haven't seen a case yet, right? But we know there are a lot of cases that we have at our site, let alone. And so that's kind of like, okay, maybe it exists, but I'm not quite sure yet. I haven't seen it. The preparation phase. So they scored let's say, for example, we'll ask what the MyFast score was, and the registered dietitian say, okay, they scored high on the MyFast 2.0 scale, but we still need more info before we know if it's food addiction or binge eating disorder. So there's a big separation that our clinicians tend to take of it has to be food addiction or binge eating, when in fact it can be both, right? And so there's a lot of hesitancy that they have of I need so much information before I'm going to move forward with doing it. Now we're in the action phase, right? My client has the MyFest 2.0 score of this, right? A high score. And therefore, they have the diagnosis and taking into the context of their entire history. And I walked my client through the treatment protocol. I gave them those options of treatment as usual, harm reduction, the abstinence-based approach. Great, okay, we're doing steps and actually doing treatment and offering different options to our patient. The maintenance phase, okay. I don't know what to do when my patient says they want to do treatment as usual. Similar to substance addiction or process addiction, when our patient, we're working with them and they have an alcohol use disorder and they say, I don't want to be abstinent, we're not just going to stop and say, okay, fine, right? So our clinicians we're seeing tend to get stuck at that point when there's any defensiveness that comes up or when there's any defensiveness that comes up. So how do we encourage them to keep moving forward and keep trying? We're not just going to give up on that patient. And relapse, my client was defensive and felt like it would increase their anorexia, so I didn't want to harm them, right? That's a big thing. I don't want to do harm, but really it's just colluding with the disease, right? It's not actually doing it. You're not harming them. You're just helping them. You're asking Socratic questions to help them open up their thought processes, right? Another example, even in interviewing, that has been one of our challenging pieces with registered dietitians. SunCloud is known for, we're very honest that we do treat food addiction, which again, there's that stigma. And, sorry, I lost my spot. Presentation is not over yet, I'm sorry. Okay. Thank you. But what I was saying, at least,
One earlier. One before.
thank you. We knew this was going to happen to somebody, and I'm thankful it was me. So with the I can't hone in enough how hard it is to break through the myth that exists, that food addiction exists, right? So some things that our registered dietitians will say, it's very rare that anyone has food addiction. No, it's not, right? We're finding out that it is not. So that's not the true myth. I have never worked with anyone who has food addiction. You saw in my example before, that was one of the examples that I've heard from the dietitians. But they have binge eating disorder, not food addiction. Again, similar. I need more data and before I can move forward with the diagnosis. How do I know I'm not harming them? This is going to make their restriction worse, right? So there's the big belief that Dr. Kim also shared a lot of. If I tell them to take this food out of their meal plan, then they're going to continue to restrict more and their anorexia is going to get worse, right? That's also important. All foods fit. How can we say that when there's different diseases like celiac disease that we can't give somebody gluten if they're allergic to it, right? And so how can all foods fit in for every patient possible? So that's also a common misconception. The diet culture phenomenon and intuitive eating is also very much myth. So with that, the other difficulties that we do face are like I just want a very big takeaway home piece is how resistant the registered dietitians and our field in general of eating disorders is to food addiction. So that's just the big piece. Now, I'm going to go into an interview that I had with a candidate that I was working with our director of nutritional services and our director of operations, because it's really hard to find registered dietitians who are open to the food addiction, especially if they've been in the field a long time. And it's hard because we want people who have been trained in eating disorders to work with us, right? So this is somebody who's had a lot of experience in the field, and this is an interview. The director of operations starts the interview, and the dietitian has an extensive background in treating eating disorders. And they start off, we didn't mention anything about food addiction in that first interview. And they're like, I'm so excited. I'm very interested in coming on board with you, right? Second interview was myself and our director of nutritional services. And we brought up the idea of food addiction in there. So we're slowly bringing it in because we know there's a lot of pushback, but we do need to see where people are at and their openness in treating them. And so we ask, is this a concept you're open to? And usually I get an answer of like, I have to look more into it. I'm not quite sure, but I guess my concern is how do you stop patients from restricting when treating food addiction? So that piece keeps coming up. Okay, so they're a little bit more hesitant, right? Third interview, the candidate calls, or they were more open on the second. On the third interview, the candidate calls back after doing this, and they're like, no, actually, I'm not interested in working with you all. I can't do it with the food addiction piece, right? Okay, the candidate calls back again 2 days later and says, and we have a conversation and say, okay, let's talk about it. What are your fears? What are you worried about? Are you open? And then they go, okay, you know what? Now that we've talked about it and you've shared and addressed what my fears are, I'm interested. And then they come back again and they decline the job offer because of that food addiction piece. So just talking about the tenuous process of how hard it is to even get registered dietitians who are open to the food addiction process and treatment. All right, so this is an example of a vignette with a patient who is a clinician and also has an eating disorder. And the first thing that they said to us when they walk in the door is that I know you guys are about food addiction. I'm not interested in that. That's something that, like, please don't bring up to me, right? They're sitting at meal support. They overhear a patient talking about food addiction and that there was various options given. So those 3 options again. And they're like, maybe I am interested. So they talk to their therapist and their dietitian, say, well, I heard a patient saying that. What are the options, right? And the patient provided us information about and we shared more information about the MyFast and what it does. And the origins of ultra-processed food addiction went into more of that psychoeducation piece. And they said at the end, I understand how ultra-processed food addiction is intertwined with eating disorders. It can also be its own diagnosis of an ED, even though it's still different, that food addiction and eating disorder, those are 2 different things. But you see the flexibility in their brain and their cognitive thought processes start to shift, and that openness happens. But it's a very patient process as working with addictions is. Thank you, everybody, very much. And we'll open it up to comments and questions.
How long does it take to retrain the brain?
So that's something that there's no data on, because as I think Tim mentioned, there's very little research right now into the treatment of this phenomenon, which is hard to do when it's not in the DSM or the ICD, right? We would expect, when the data doesn't exist in the literature, we rely on our clinical experience and similar research. So I would expect that it's similar to what we see from alcohol use disorder, other substances. So it's not something that's gonna heal in 30 days, in a 30-day residential, right? We're looking really at 6, 12, sometimes years. And I think part of that is also connected to when a person does have trauma, and the overwhelming majority of our patients do, how well or not are we also addressing the PTSD, the complex PTSD, right? If we're not addressing that, then I think we don't get the same kind of long-term results.
So that was a really great comprehensive talk. And so I really enjoyed listening to it. And when you treat someone with a substance use disorder and they're recovering, do you find that the food addiction, binge eating, those kind of behaviors sort of emerge as the patient is in recovery from substance use disorder?
Very often, or they had a history of an eating disorder, right? This is part of why what Cindy has been able to do with our clinicians like Nikki, pay attention to the results, especially after, let's say somebody starts at the residential level of care, they're in a controlled setting, they come in for a substance use disorder and depression, and lo and behold, staff starts noticing, hey, they're going back 5 times to the kitchen for more, or whatever, right? And then we look at the EDEQ, we look at the bypass, and particularly on that last, the one that's done at discharge from residential, you can already start to see for some of our patients. In the addiction world, it's referred to as switching, right?
Exactly.
So we most definitely see that.
I mean, it's great that you were able to pick up on something that, emerges later.
Well, I think we're taking a great deal. I'm just curious about your program and what investigation the inclusion of food addiction into the program. That's, I think, all good. It's not a diagnosis that's recognized. So there is what do you think it is that the diagnosis of food addiction will add to treatment to the patient outcome policy?
It's a great question. I think there's tremendous potential for policy improvement, right? In hospitals, we don't have cigarette vending machines, right? We never would do that. Back in the day, they were there, right? Not anymore, because we know the public health, the medical risk and the morbidity and mortality associated with that substance. And that data is emerging with ultra-processed foods, right? But when we look at residentials, when we look at hospitals, what are we serving? Like, nobody's getting whole foods, right? Served to their room. Too expensive. So I think on the policy end, there's tremendous potential for labeling foods by risk of harm, with regards to cancers, with regards to cardiovascular disease, with regards to food addiction, and depression and anxiety. And that research is coming in. And why did we include this? In part because of my experience, and because we see it all the time, and we pay attention to the research. The eating disorder people view the food addiction research as, this is all made up. It's almost delusional strength, because it's so threatening to a field where the dogma has been all foods fit for all patients, and our job is to help people eat with freedom.
Yes, I would add to that just person who's been in the eating disorder field for 40 years, and just seeing, first off, the resistance to incorporating, acknowledging trauma and PTSD in the eating disorder field, which I've done a lot of work to try to counter that, and now it's really more of an accepted thing. But just seeing the research explode, as I mentioned earlier, over the last 15, 20 years especially, but yet this incredible resistance in the eating disorder field and eating disorder programs of even acknowledging or doing any research on food addiction, even though it's clearly a thing in the literature. SunCloud was one of the only people or places that was open to doing research, as well as interfacing with the trauma story, the PTSD story. So, and we're not saying we have all the answers, but we need to collect the data to see how it unfolds. And just there's such a resistance, I can't overemphasize that, in the eating disorder field toward this. And, you know, I think it's changing though, slowly but surely.
It's more, I think it may be more recognized in the substance use disorder field. I know there was there was some concept of it in the response to normal actually, yeah, it was really on food addiction. So,
Yeah, I think for sure the addiction field is more open to this concept and the sort of, like Kim said earlier, there's been a lot of stigma about addiction in the eating disorder field, and even in psychiatry. You know, the word addiction did not appear in the DSM until the fifth edition. Literally, it did not appear ever in DSM 1, 2, 3, and 4. Only recently, in 2013, is that word even been used in development.
Yeah, you know, I think the book that Tim shared, Gerhardt, Gold, Potenza, these are names in the eating disorder field that are just ignored, you know, and seen as harmful to patients with eating disorders. In the addiction world, these are giants, right? And I'll share a little vignette with you. So one of the international eating disorder organizations is the Academy for Eating Disorders, and they have a special interest group that was shut down, and then a colleague, David Wiss, and I we had to go through. It took about a year to get it reopened. It's the substance related and addictive disorders special interest group. And we tried to, part of what we do is do webinars quarterly. And we submitted to do a webinar on exercise addiction. And it was, you know, you have to change this, you have to change that. You can't call it exercise addiction. There's no data on that. You can call it compulsive exercise, but don't use the addiction. I mean, that's just a small snippet of the kinds of craziness, really, and the kinds of emotionality that comes up around addiction and eating disorder.
well, even addictions come out of the, you know, everything's changed to sort of an individual with a substance use disorder. So I'm wondering if, you know, maybe to rename it. So,
Yes.
Well, there is a major impetus to get ultra-processed food addiction into the ICD system, and then there's a parallel effort run by Ashley Gerhardt to get ultra-processed food use disorder into DSM-6. And so, again, there's a lot of data that I think support that concept. I think it will evolve just like binge eating disorder. It took decades for binge eating disorder to get it. Gambling disorder, so many other things.
Thank you, everybody, for a wonderful presentation. And I come from the PTSD trauma world, and obviously so much to do in the future in terms of the convergence of these comorbidities. But I was wondering, you know, as an alternative, I know that there's the going down the line of, you know, identifying diagnosable problems, because of course, you know, if you don't have a diagnosis, then there's no treatment, there's no funding for the treatment, and all that kind of thing. So I completely get that. But as an alternative, I think a lot of us, especially when we do co-production with individuals with lived experience, the feeling is, I don't want another diagnosis. I want to be seen as a whole person. I think you guys spoke to that. But the whole movement around a recovery-oriented approach, which focuses on quality of life, like you have done in your assessment process, I'm wondering how that sort of fits in, and also the autoimmune issues that, at least in people with PTSD, and I have a feeling in your populations that are overlapping, you know, we're also seeing a lot of autoimmune issues, and it's sort of like helping people get better, doing better self-care, focusing in on their wellness, and not only thinking about symptom reduction, but obviously food and the kinds of food you eat is a critical component to that. So I just wondered what your thoughts were about that. Maybe that's just, you know.
Again, I think in the eating, I think in the substance use addiction treatment world, well, focus on wellness, focus on health, is focus on exercise is very common in addiction treatment centers and among addiction patients. In the eating disorder world, it's the opposite. Right, again, stemming from the overwhelming number of studies that eating disorder treatment and evidence-based treatments rest on are the early studies that were predominantly from white, restricting types of eating disorders. And that's not the patients. You know, that is not consistent with the most common type of eating disorder, which are out of control eating disorders, right? And in the eating disorder world, anything that has any whiff of, you know, if you tell me to exercise, you're supporting me losing weight. If you tell me to, you know, consider a low salt meal plan because I have hypertension, you're harming that patient because you're restricting what they can eat rather than giving them freedom and all of this. So there's a neglect of and a blind eye turned towards really serious, you know, morbidity conferring and mortality conferring medical problems, autoimmune disorders, which respond to nutritional interventions. Like, you know, there are people who don't have celiac disease who feel much better physically and mentally eating a meal plan that doesn't include gluten. That would be unheard of in the eating disorder world, you know, and thought of as you are harming that patient by even suggesting something.
I think one way that this is beginning to take traction is the realization that ultra-processed foods are harmful. They increase inflammation. They're associated with a number of different medical conditions down the road. And so that's, I think, a thing that is beginning to be, it's hard to ignore that they're associated with cardiovascular disease, diabetes, kidney disease, and cancer, and autoimmune disorders. So even though one can deny that they may be addicting, it's harder to deny that they're harmful. And the fact that in grocery stores, at least in the United States, 70% of what you see in the grocery store is ultra-processed food. And so the other thing that speaks to the gentleman from Melbourne that occurs to me is that in terms of treatment, particularly in the binge related disorders, bulimia, binge eating disorder, there's a large relapse rate, a very high relapse rate, and long-term recovery rates are very, very low. And yet the treatment is that you must eat these foods. When someone with binge eating disorder goes into an eating disorder treatment program or bulimia nervosa, they're forced to eat these ultra-processed foods in moderation. Yet we have very low long-term recovery rates. When maybe, just maybe, people need to abstain or really significantly reduce these types of foods. The type of food is not really been a focus in the eating disorder world. It's really more the individual, right, than what they're eating. So that, I think, is just another aspect to it in terms of why this is so important.
It's it's really thought of as a psychological illness rather than a biopsychosocial spiritual illness, right? And along the lines of, is the substance in the food impacting the individual's biology? We would never, ever, ever, for somebody who had alcohol use disorder in our residential or PhD program, say, okay, you're doing so great, now let's do a challenge. We're gonna give you a glass of wine or a shot of Jack Daniels with your dinner. And we're gonna, do an exposure, we're gonna support you in drinking like a lady, right? We would never do that, but we do that. It is the rule in eating disorder treatment centers. One, because, and Tim has had this experience, other eating disorder centers that are doing research will not even administer the Yale food addiction scale because even administering the scale is seen as harmful, right? So, they don't know that it's there in the patient, and it most likely is a missing piece that leaves us with, 60 or 70% of people with binge eating disorder not achieving long-term recovery.
So I'm just going to make a follow-up comment, slightly tangential to what we just talked about. One of the implications, I suppose, of classifying anything as an addiction is that it implies a loss of control of the use of that substance. Basically, inherent in that is a impetus for policymakers to start to regulate the substance or restrict access to substance for vulnerable populations. And when working in policy, I imagine there's always this balance to achieve the individual freedom, person's choice for what they consume. So my question is, do we think that there's enough evidence and literature out there to suggest that there is enough of the population that is affected by this ultra-processed food to indicate this as a problem?
I think the short answer is yes. And if you look at the literature on ultra-processed foods, there have been a number of major publications with very, very large sample sizes just in the last 3 to 5 years that are associating ultra-processed foods with a host of all of the leading causes of death that I've named previously. So a resounding yes. I think these kinds of publications are finally getting people's attention. But I think big food, just like we had big tobacco and big pharma, they are very powerful. And a lot of people don't know this, but once, remember in the United States when all the tobacco executives got before Congress and denied that nicotine was addicting? Well, the same thing is happening in regard to ultra-processed foods. But once the cat was out of the bag about nicotine being addicting, the very people who own big tobacco then bought big food corporations. They're the same people, and they're using the same kind of playbook to engineer food that is irresistible. And so, we've seen this same these same kind of behaviors before in big corporations that are out to make money, make a buck.
And I think just on the freedom, freedom of choice piece, I think that's an important piece too, because we have, if you're of a certain age, you can buy alcohol. You can buy cannabis in the States, in most states. Food is something we have access to, at the youngest age. There's some research coming out around impact of ultra-processed food on young kids, and they're exposed to it at very, very young ages. And one of the things that I think is hardest, it's similar to treating somebody with cannabis use disorder, right? The amotivational syndrome diminishes their capacity, I think in some ways, a much more profound way than somebody who's using heroin, right? Like, I still go to work. I'm involved with my family, but they all say I'm kind of absent. I don't really have any motivation to do anything different. I can go to the store and get it. It's sort of like addiction by stealth, almost. And we see that with food addiction because it's so prevalent and so pervasive. And the norm is, eat ultra-processed foods. And when people have addiction, they don't have the freedom of choice. Many people with addiction think they have the freedom of choice, right? And when it's something that's, 70% available, like all the food in our grocery store, 70% of it is ultra-processed foods. And it's so built into our culture and into social interactions from a very, very young age. I think the question of, if we say to somebody, which we do all the time in medicine, if you keep eating in this way, you're going to die of a heart attack. That doesn't make people stop eating. And I don't think that's because they have freedom of choice. Right? I think that's because they can't stop.
Great research. Really proud to be a part of it. You guys are at the forefront of some pretty big stuff, so thank you.
We appreciate your coming today.